Welcome back to the deep dive. Today, we are wading into waters that I think, for the vast majority of people, are defined by exactly one emotion:
Mm.
panic. Pure, unadulterated panic.
It is a heavy topic.
Yes.
And you're right about the panic. It is. It's almost Pavlovian.
Right. We're talking about breast alterations today. And I don't care how rational you are. I don't care how much medical drama you watch or how well read you are. The second you feel a lump or a weird pain or you see a change in the mirror, your brain does not go to, oh, maybe it's a cyst.
No, never.
It goes straight to the catastrophic.
It's a universal reflex.
Yeah.
You feel a change in the tissue, and the internal monologue immediately screams, cancer. It translates directly to anxiety, distress, and a fear of mortality.
Yeah.
It's visceral.
Exactly. It's the 3 a.m. stare at the ceiling terror. But our mission today is to take that fear and dismantle it with information. We're looking at a stack of clinical notes, nursing guidelines, and pathology reports on reproductive health. And the goal is to move from that reactive fear to proactive understanding. We're going to unpack the anatomy, the hormones that drive these changes, and the actual risks involved.
And if I can offer a statistic right at the pop to perhaps lower the collective heart rate of everyone listening,
Please do. I think we all need it.
benign breast disease, or BBD, accounts for approximately 90% of primary care visits for breast complaints.
I saw that number in the papers and I had to double check it. 90%.
90, as in 90. That means 9 out of 10 times the scare, the lump, the pain, the discharge that keeps you up at night is not cancer.
So the vast majority of these situations are not malignancies.
The vast majority are not. It's a benign condition.
That is a staggering number because
Yeah.
when you are in that waiting room, wearing the paper gown, it feels like a coin flip. It feels like 50-50.
It feels that way because of the weight of the potential bad news.
Huh.
The psychological weight of the C word is so heavy it distorts the probability in our heads. But clinically, statistically, benign conditions are overwhelmingly more common. And that's really the roadmap for our discussion today.
Yeah.
We're going to start with those benign conditions, things like cysts and fibroadenomas, and understand why they happen.
Right.
Then we'll move into infections like mastitis, and finally we will tackle the serious side with malignancy, genetics, and risk management.
And one thing that really stood out to me in the source material we're using is that it's heavily focused on the nursing and clinical management perspective. It's not just a medical textbook of pathologies.
No, it's not.
It's about how clinicians interact with patients.
That is a crucial distinction. In this field, the clinician's role, especially the nurse's role, isn't just about finding the lump or ordering the test. It's fundamentally about emotional support. It's about education.
Okay.
When a patient comes in with a breast complaint, they are often in a state of high anxiety. The provider's role is to act as a guide through that anxiety, providing reassurance and clarity.
So it's about managing the human, not just the tissue. So let's dive into the most common reason a person might find themselves in that exam room. We're starting with something called fibrocystic disease, or FCD.
FCD, yes. It is one of the most common types of benign breast disease.
The sources describe the physical sensation of this condition with a very specific, very memorable phrase. They call it lumpy and bumpy.
It's the classic description. Lumpy and bumpy. It's almost onomatopoeic for how it feels.
It sounds almost cartoonish, like a description of a bad mattress, but I imagine the reality is quite uncomfortable.
It is. If you're doing a self-check, what you're feeling isn't usually a single hard rock. It's more like, well, some describe it as a bag of frozen peas or cobblestones under the skin.
Okay.
Anatomically, what you're feeling is fibrosis, which is a thickening of the connective tissue and cyst formation. It creates this nodular, almost rope-like texture.
Now, before we get into the symptoms, I want to clarify the risk, because this is the first question everyone asks. If I have fibrocystic disease, if I have this fibrosis, does that mean my cells are starting to act weird? Is this the first step toward cancer?
This is the most important takeaway for FCD. It is classified as non-proliferative.
Let's unpack that word, non-proliferative.
So in cancer, the problem is proliferation cells dividing uncontrollably.
Right, multiplying.
Exactly. Non-proliferative means that while the tissue is changing texture, it's getting thicker, it's holding fluid, the cells themselves are not multiplying dangerously. They aren't mutating.
So in plain
In
English,
plain English, there is no increased risk for future breast cancer associated with this specific condition.
that is huge. So you can have very lumpy, very scary feeling breasts, but the risk meter is effectively at zero.
Correct. It's a benign process. It's a crucial distinction for peace of mind.
Okay, but if it's not cancer and it's not leading to cancer, why is it happening? Why do some people get this lumpy, bumpy texture and others don't? What
Right.
is the mechanism?
It's the hormonal engine at work.
Right.
The etiology, the cause, is driven almost entirely by the reproductive cycle.
Of course.
Specifically, the interplay between estrogen and progesterone.
The usual suspects.
Indeed. Think about what the breast is designed to do biologically. Every single month, your body prepares for a potential pregnancy. Estrogen surges and tells the breast tissue, get ready, expand, grow the ducts.
Uh-huh.
Then progesterone comes along and says, mature the milk glands.
Like a monthly renovation project.
Exactly. But in women with FCD, the tissue is hypersensitive to these orders. The renovation goes overboard.
It overreacts.
It overreacts. The tissue swells, it retains fluid, the connective tissue gets thick and fibrous, and then when no pregnancy happens, the hormones drop and the tissue has to reset. But over time, that constant cycle of swelling and receding leaves behind this nodular, cystic texture.
This explains why the notes say this primarily affects premenopausal clients, right? Ages 30 to 50.
Precisely. It's a condition of the reproductive years. You need that active cycling hormonal engine to drive the symptoms.
So when you hit menopause,
Once you hit menopause and the factory shuts down, so to speak, the symptoms of FCD usually disappear.
the notes mention that this affects more than 50% of females over age 30. That's a coin flip.
It is incredibly common. It's almost a variation of normal physiology rather than a disease in the traditional sense, although it can be very symptomatic and very distressing.
Let's talk about those symptoms. If I'm dealing with this, what am I actually feeling besides the lumps?
The hallmark is mastalgia breast pain, and it's usually described as dull, aching, and heavy. It's often bilateral, meaning it affects both breasts, and it tends to be worse in the upper outer quadrants up near the armpit.
And you mentioned tenderness and swelling.
Yes. But here is the key, the aha moment for diagnosis that separates this from something more sinister. These lumps and this pain are cyclical.
Cyclical, meaning they follow the calendar.
They follow the tide of the hormones. The symptoms fluctuate with the menstrual cycle. They tend to peak or worsen during the luteal phase. That's the week or so just before menstruation starts.
When estrogen is stimulating the tissue the most.
Precisely. The breasts feel fuller, more painful, and lumpier right before the period. Then, once menstruation begins and the hormone levels drop, the symptoms improve.
So the lumps might actually shrink.
They might even shrink or feel less prominent. It's a very clear pattern.
That seems like a really useful way for someone to self-check. If the lump hurts today but is gone next week after your period, it's likely FCD.
That is exactly the logic clinicians use. Contrast that with malignancy cancer. Cancer is typically non-cyclical. It doesn't care what day of the month it is.
It's just there.
It's just there. It's usually painless, and the lump is fixed. It doesn't move.
So, weirdly, pain is actually a somewhat reassuring sign in this context.
Paradoxically, yes. Pain usually points to inflammation or hormonal tension, which are hallmarks of benign conditions. Early-stage cancer is often silent and painless.
Now, you mentioned this happens to 50% of women, but is there a why me aspect here? Are there lifestyle factors that make someone more prone to this lumpy, painful reality?
There are. And this is where we get into the inflammatory connection. It turns out how we live affects how our hormones behave.
Is it the diet? It's always the diet.
It is often the diet. The source material highlights that a diet high in inflammatory foods can increase estrogenic activity and tissue inflammation.
So we're talking about, what, saturated fats, sugar?
We're talking about saturated fats, trans fats, fried foods, and high glycemic carbohydrates.
So the stuff that tastes good inflames the tissue.
Unfortunately. There's a specific mechanism here. High fat intake is linked to higher estrogen levels. And remember, estrogen is the fuel for this fire. The more fuel you have, the bigger the fire.
What about caffeine? I feel like every time someone has breast pain, they're told to quit coffee.
It's the classic advice. The scientific evidence is actually a bit mixed, but clinically, we see it work all the time.
So there's something to it.
There seems to be. Caffeine contains methylxanthines. These chemicals can cause blood vessels to dilate and may increase tissue swelling and sensitivity.
So the coffee literally puffs up the tissue.
In a sense, yes. For many women, cutting out coffee and chocolate leads to a significant drop in tenderness. It's a low-risk intervention, so it's always worth a try.
And alcohol. Is that in the same category?
Alcohol is a clearer link. Alcohol consumption increases serum estrogen levels.
How does that work? Is there estrogen in the wine?
No, it's about the liver. Think of your liver as like a busy traffic controller. It has to process everything, toxins, alcohol, hormones. If you drink alcohol, the liver prioritizes clearing that toxin.
It's the most urgent job.
It's like the alcohol cuts to the front of the line.
So the estrogen gets stuck in the queue.
Exactly. The liver's busy with the Chardonnay, so the estrogen isn't metabolized and cleared out as efficiently. It recirculates in the body.
And more circulating estrogen means more stimulation for the breast tissue.
You've got it. It's a queuing problem.
That is a fantastic analogy. It leads me to another risk factor mentioned: obesity.
This is a critical point that we will circle back to later regarding cancer as well. There's a connection between obesity and breast alterations, because adipose tissue body fat is not just inert storage.
It's not just sitting there.
It's not. It produces estrogen.
Wait, fat cells produce estrogen? I thought that was just the ovaries.
They do. Adipose tissue acts as an endocrine organ. It synthesizes estrogen. So the more body fat you have, the higher your circulating estrogen levels are, and the more stimulation your breast tissue receives.
That is a massive concept. The idea that our body fat is pumping out hormones that affect our breast tissue is, well, it's wild.
It redefines how we look at weight management. It's not just about mechanics or heart health. It's about hormonal balance.
There was one other point in the notes that I found sort of paradoxical: the protective paradox of oral contraceptives.
Right. It seems counterintuitive because we just said hormones drive this. Why would adding hormones help? But oral contraceptives, the pill, can actually reduce the risk of FCD symptoms
How does that work?
because they suppress the natural ovulation cycle. They flatten the hormonal spike. Instead of the roller coaster of natural estrogen and progesterone peaks that whip the breast tissue into a frenzy, you get a steady, controlled, lower dose.
So it calms the storm.
It calms the storm. Whereas hormone replacement therapy, or HRT, which is often used later in life, can increase the risk because it's adding fuel back to the fire.
Got it. So let's talk management. If I'm listening to this and nodding along because my breasts hurt every month and feel like a bag of marbles, what do I do? The source had some practical steps.
First, mechanical support. A supportive bra. It sounds simple, but reducing ligament strain makes a huge difference in that heavy, aching feeling.
Makes sense.
Second, salt restriction, especially in the week before your period.
Salt. Why salt?
Salt causes fluid retention. Fluid retention leads to swelling. Swelling in the breast tissue equals pain. Cutting back on salty foods can really reduce that pre-period heaviness. Yeah. Then there are NSAIDs, ibuprofen, or naproxen for the inflammation. But the most important tool for the patient is the symptom diary.
This connects back to the cyclical nature.
Yes, the nurse should encourage the client to track the pain, the swelling, and the lump changes against their menstrual cycle. This confirms that benign cyclical pattern we talked about.
And it's data.
It's data. It provides evidence that says, look, this isn't random, this is hormonal. That realization alone brings a lot of relief.
And if the diary isn't enough, if the doctor wants to be sure,
then we move to diagnostics. Mammography is the standard, and for FCD, you're looking for a BI-RADS2 classification, which means benign finding.
But the notes say ultrasound is sometimes better.
For younger clients, yes. Younger women tend to have denser breast tissue. On a mammogram, dense tissue looks white, and so do tumors.
So you can't see anything.
It's like trying to find a polar bear in a snowstorm. Ultrasound is much better at differentiating between a solid mass and a fluid-filled cyst. And cysts are the hallmark of FCD.
And biopsy. When does that come in?
Biopsy is the last resort. It's only used if things look suspicious, if there's a solid mass that isn't a cyst, or if the symptoms don't follow the cycle.
Okay, so that's fibrocystic disease, the lumpy, bumpy, painful, but ultimately benign condition of the reproductive years. Now, I want to pivot to the second big category in our source material. This one has perhaps the weirdest nickname I've ever heard in a medical context.
You must be referring to the breast mouse.
The breast mouse. This is the nickname for fibroadenomas.
It's a vivid description, isn't it?
It is. Why on earth do they call it that?
It refers to the tactile sensation. A fibroadenoma is the most common benign tumor, usually found in a younger demographic, ages, say, 17 to 35.
Younger, okay.
And when you try to palpate it or feel it with your fingers, it is incredibly mobile. It slips around under your fingers almost like a mouse running away from you.
That is both helpful and slightly disturbing.
It's very distinctive. Unlike a cancer, which is often fixed or stuck to the surrounding tissue. Imagine a stone glued to the wall. A fibroadenoma is non-tender, rubbery, firm, and has very well-defined borders. It's encapsulated like a little island, so it slides.
So FCD is lumpy bumpy and a general texture change. Fibroadenoma is a distinct, defined lump that moves.
Correct. It's a solid tumor, not a cyst.
Now, we talked about risk with FCD being 0. What about fibroadenomas? Is it the same story?
This is where we need a bit of nuance. Fibroadenomas are classified as proliferative without atypia.
Okay, let's unpack that jargon again. Proliferative without atypia.
Proliferative means there is cell growth. It is a tumor, after all. The cells are multiplying to create this mass. But without atypia means the cells look normal under the microscope. They aren't weird or mutated. They aren't behaving like cancer cells.
And the risk factor.
This carries a slight increased risk for future breast cancer compared to non-proliferative lesions like FCD. But, and this is a big but, they are still fundamentally benign. The risk is small. It's not a precancerous lesion in the scary sense, but it does suggest the tissue is a bit more active.
So it's not no risk, but it's low risk.
Exactly. It's something that warrants monitoring.
Are these also driven by hormones? Does that pattern hold?
It does. These are estrogen-sensitive tumors.
So we see them grow when estrogen is high.
Yes. Pregnancy is a major trigger. Because pregnancy is a state of massive estrogen production, fibroadenomas can grow quite rapidly during pregnancy.
And shrink when it's low.
Conversely, during menopause, when estrogen levels plummet, the incidence decreases, and existing tumors may even shrink or calcify over time.
That makes perfect sense. Now let's look at the age group again, 17 to 35.
Yeah.
That is a terrifying age to find a lurk. You're in college or just starting your career and suddenly you feel a mass.
It is traumatic. And because breast cancer is so rare in that age group, the diagnostic protocol is different.
How so?
We don't typically do mammograms on a 20-year-old.
Because of the density we just talked about.
Exactly. Young breast tissue is extremely dense. The gold standard for this age group is ultrasound.
Which uses sound waves to see the borders.
Precisely. Ultrasound can clearly see the edges of the fibroadenoma and tell us it's solid. However, even with a great ultrasound, a biopsy is often needed to provide the definitive diagnosis, just to be absolutely sure it's not something else.
So let's say a 25-year-old woman finds one of these mice. The ultrasound says it looks like a fibroadenoma. Does she have to have surgery? Do you have to cut it out?
Not always. In fact, conservative management is very common.
Watch and wait.
Watch and wait.
Mm-hmm.
If the tumor is small, say less than 3 or 4 centimeters, and it's slow growing, and the biopsy confirms it's benign, we often just leave it alone. We monitor it with follow-up ultrasounds to make sure it's not getting huge.
But I imagine for some people, knowing there is a tumor in their breast, even a benign one, causes a lot of anxiety. It feels like walking around with a time bomb, even if the doctor says the fuse isn't lit.
Absolutely.
Yeah.
The clinical management part of our sources emphasizes this. The psychological burden is real. If the patient is extremely anxious, or if the tumor is growing rapidly, or if it's causing deformity or pain, we have surgical options.
Like what? A lumpectomy?
Excision, which is a lumpectomy, cutting it out. Or a newer option called cryoablation.
Cryoablation? That sounds sci-fi.
It's fascinating technology. It's essentially freezing the tissue. They insert a thin probe into the center of the fibroadenoma and use liquid nitrogen to freeze the tumor from the inside out.
So it kills the cells in place?
Yes, the cells die, and over time, the body's immune system cleans up the debris and the lump shrinks away. It's much less invasive than open surgery, leaves a tiny scar, and recovery is fast.
That is incredible. So we have FCD hormonal texture changes. We have fibroadenomas, hormonal benign tumors. Now I want to shift gears completely. We're leaving the land of tumors and cysts and entering the land of infection.
Mastitis.
Mastitis. This is a word that strikes fear into the heart of every new mother.
With good reason.
Yeah.
It is painful and intense.
The sources focus heavily on lactational mastitis. Set the scene for us. When does this happen?
The most common scenario is the first 3 months postpartum. You have a new baby, you're exhausted, you're trying to establish breastfeeding, and suddenly, wham.
And what is the actual cause? Is it just milk buildup?
It's a bacterial infection, usually Staphylococcus aureus, but the bacteria needs an entry point. It typically gets in through cracked or traumatized nipples.
Which are very common in early breastfeeding when the latch isn't perfect yet.
Extremely common. But the bacteria is only the seed. The soil that allows it to grow is milk stasis.
Milk stasis, the milk stops moving.
Exactly. Think of a flowing river versus a stagnant pond. A fast-moving river stays clean. A stagnant pond grows algae and bacteria.
Good analogy.
If the breast isn't emptying completely, maybe the latch is bad or there's an oversupply, you skipped a feeding, the milk sits there. That stasis allows the bacteria to multiply rapidly.
And the symptoms are not subtle.
No. You don't just feel a little off. It's redness, heat, swelling, and extreme pain in the breast. But it's also systemic. You get high fevers, chills, body aches. It feels like you've been hit by a truck with the flu, plus your breast is on fire.
Here is where the deep dive really matters because there is a massive myth here. My instinct, and I think a lot of people's instinct, would be, oh my God, my breast is infected, there's bacteria, I should stop breastfeeding.
That is the instinct.
I shouldn't give that milk to the baby, and it hurts too much to nurse anyway.
And it is arguably the most dangerous thing you can do.
Dangerous. How?
Yes, the source material is explicit. You must continue breastfeeding or pumping.
Why? Even with the infection?
Because emptying the breast is the cure for the stasis. If you stop breastfeeding, the milk sits there, the pressure builds, the bacteria multiplies even faster. And if you let that infection sit in a pressurized, stagnant environment, you risk developing a breast abscess.
An abscess. A pocket of pus.
A pocket of pus that has to be surgically drained. You do not want that. So the cure is flow.
So you have to nurse through the pain.
You have to keep the river moving to flush out the bacteria.
Yeah.
The milk is safe for the baby. The baby's stomach acid handles the bacteria without issue, but the flow is critical for the mother's recovery.
That is tough love clinical management. I know you are in agony, but you have to keep going.
It is. The management guidelines suggest using a warm compress before feeding. The heat dilates the ducts and helps the milk flow. Then use a cold compress after feeding to reduce the inflammation and pain.
And lots of water, I assume.
Hydration is key,
Yeah.
and antibiotics are prescribed if there's a fever or flu-like symptoms.
Okay. But the notes also mention non-lactational mastitis. This can happen to people who aren't breastfeeding.
It can. It's less common, but important to know about. There is periductal mastitis, which is inflammation around the areola.
Is there a specific risk factor for that?
There is a heavy association with cigarette smoking.
Smoking. We usually associate smoking with lungs and heart. How does it affect the breast?
It's about the toxins in the blood vessels. Smoking damages the epithelial cells that line the ducts behind the nipple. It also constricts blood flow, which impairs healing. So you get these chronic, recurring infections and abscesses around the nipple.
So if you have recurring breast infections and you aren't breastfeeding, the first question is, do you smoke?
Correct. There's also a rare condition called granulomatous mastitis, which can be scary because it mimics cancer. It can cause ulcerations and a hard mass. It requires careful diagnosis to rule out malignancy.
It seems like mimics cancer is a recurring theme here.
It is, which is why diagnostic precision is so vital. We can't just guess.
And that leads us to the final and most serious section of our deep dive. We've covered the 90% that is benign. Now we have to talk about the malignancy. Breast cancer.
This is the shift from reassuring physiology to serious pathology. But again, knowledge is power here.
Before we get into the scary stuff, let's do a quick anatomy refresher because the types of cancer are named after the parts of the breast they affect. We have lobules and ducts.
Right. Think of the breast as a milk production system. The lobules are the factories. They are the clusters of cells that actually produce the milk.
Okay, lobules are factories.
The ducts are the highways. They are the tubes that carry the milk from the lobules to the nipple.
Factories and highways? Simple enough.
Most breast cancers are carcinomas, meaning they start in the epithelial cells that line these structures.
And which is more common, the factory or the highway?
A highway. Invasive ductal carcinoma, IDC, is the heavyweight. It accounts for 70 to 80% of all cases. It starts in the milk highways and invades outward into the surrounding tissue.
And the lobular?
Invasive lobular carcinoma, ILC, accounts for about 8%. It starts in the factories.
And what does in situ mean? You hear ductal carcinoma in situ a lot?
In situ literally means in its original place. Think of it as a cancer that is currently in jail. The cancer cells are there, inside the duct or the lobule, but they have not broken through the wall.
They're contained.
They're contained. They haven't invaded the surrounding tissue yet. This is the earliest stage, stage 0, and it's highly treatable because it hasn't spread.
Okay. Now let's go back to the lumpy bumpy conversation. How does a patient or a nurse tell the difference between the FCD lump we talked about earlier and a cancerous lump? What are the red flags?
We contrast the findings directly. Remember FCD? Mobile, tender, smooth, cyclical.
Right.
Malignancy is typically the opposite. First, the lump is painless.
Painless. That's tricky because pain is what usually drives people to the doctor.
Exactly. We tend to ignore things that don't hurt. But a painless lump is a major red flag. Second, the lump is fixed. It feels anchored to the chest wall or the skin. It doesn't slide around like the fibroadenoma.
You can't move it.
You can't. Third, it has irregular borders. It's not a smooth ball. It feels jagged or hard, like a rock. And critically, it is non-cyclical.
It doesn't follow the tide?
No. It doesn't shrink after your period. It stays and it grows.
What about visual signs, things you can see in the mirror?
In advanced stages, you look for skin changes. There's a classic sign called peau d'orange French for orange peel.
Orange peel skin.
Yes. The skin of the breast looks thickened, dimpled, and pitted, exactly like the skin of an orange. This happens because the cancer cells block the lymph vessels in the skin, causing fluid buildup or edema.
Okay.
You might also see nipple retraction, the nipple pulling inward because the tumor behind it is pulling on the ducts, or swelling in the armpit, which indicates the lymph nodes are involved.
Okay, those are clear warning signs. Now let's talk about risk. This is the part everyone wants to control. What can I do to stop this from happening?
We divide risk factors into two baskets, non-modifiable and modifiable, the hand you are dealt and how you play it.
Non-modifiable means things you're stuck with.
Correct. Age risk increases as we get older. Gender being female is the biggest risk factor, family history and genetics. And then there's something called the estrogen window.
The estrogen window, what's that?
This refers to your lifetime exposure to estrogen. If you had early menarche, meaning your period started very young, and late menopause, your window is wider. Your body has been exposed to estrogen for more years. That increases risk.
And reproductive history plays a role here too.
Yes. Nulliparity, never having given birth, or having your first child at a later age, increases risk.
Why?
Because pregnancy interrupts the cycle. For 9 months, you aren't ovulating. Your estrogen profile changes. So historically, women who had many pregnancies starting at a young age had a lower risk because their estrogen window was constantly being paused.
Which is complicated advice to give. Have babies early to prevent cancer isn't exactly a practical public health strategy for everyone.
Exactly. It's an epidemiological fact, not necessarily a life plan. It just helps us understand the biology.
So let's talk about what is actionable, the modifiable risk factors.
These are the levers we can pull. And the source material is very clear on 3 big ones: alcohol, diet, and weight.
We touched on alcohol with FCD, but it applies to cancer too.
Explicitly, alcohol consumption is linked to increased breast cancer risk. There is no safe limit stated in the notes, just that it increases risk in a linear fashion. The more you drink, the higher the risk.
And diet.
Red meat, animal fats, and refined carbs increase risk. On the flip side, fiber, whole grains, fruits, vegetables decrease risk.
So a plant-based whole food diet is protective?
It appears so. And then there is weight, specifically postmenopausal obesity.
And this goes back to the fat cells as hormone factories. I want to make sure we really nail this point because it changed how I view the human body.
It is a profound physiological shift. Before menopause, your ovaries are the main source of estrogen. After menopause, the ovaries shut down.
Right.
But your fat tissue, your adipose tissue, continues to make estrogen. It contains an enzyme called aromatase that converts other hormones into estrogen.
So in a postmenopausal woman, having excess body fat means
It means having higher circulating estrogen levels than a lean woman. You effectively have a functioning estrogen factory running 24/7 in your body fat. That estrogen continues to feed any potential cancer cells.
that is a very clear mechanism. It's not just being heavy is bad for your heart. It's being heavy provides fuel for breast cancer.
Correct. It shifts obesity from being just a metabolic issue to being an oncological issue, a cancer issue.
Yeah.
And that is a powerful piece of knowledge for patients.
We can't talk about breast cancer without talking about genetics. The Angelina Jolie effect, everyone knows about the BRCA genes now.
Yes, BRCA1 and BRCA2. But there is a massive common misconception about what these genes are.
What do you mean?
People say, oh no, I have the BRCA gene. But we all have BRCA gene.
Wait, we do. I thought it was a bad thing to have.
Yes, we all have them. BRCA stands for breast cancer gene, but their job, normally, is to be tumor suppressors. They are the repair crew. They find and fix damaged DNA. We need them.
Oh, so having the gene is good. Having a broken gene is bad.
Exactly. The risk comes from a mutation in the BRCA1 or BRCA2 gene. If the gene is mutated, the repair kit is broken. DNA damage accumulates, and that leads to cancer.
If someone tests positive for this mutation, what does that mean? Is it a diagnosis?
No, And the expert guidance emphasizes this. Genetic testing assesses risk. It does not diagnose cancer. A positive BRCA mutation means your lifetime risk is significantly higher, up to 80% in some estimates. But it's not a guarantee.
So what do you do with that information?
It guides surveillance.
Mm.
If we know you have the mutation, we don't just wait for a mammogram at age 45. We might start screening much younger. We might add MRI to the mammogram because MRI is more sensitive.
Or in some cases, surgery.
Or, like Angelina Jolie, some patients choose prophylactic mastectomy, removing the breast tissue before cancer can develop. It changes the game plan entirely.
It moves you from average risk surveillance to high risk management.
Completely.
Speaking of surveillance, let's wrap up this section by clarifying the hierarchy of tests. We've mentioned mammograms, ultrasounds, MRIs, biopsies. How do they fit together?
Think of it as a funnel. Mammogram is the screening tool. It's the wide net we cast to catch potential problems. It uses X-rays.
Step 1.
Ultrasound is for differentiation. It tells us, is this blob a fluid-filled cyst, safe, or a solid mass, concerning? It's also the go-to for young, dense breasts.
Okay.
MRI is for high-risk or very dense tissue. It's the high-definition zoom. But, and this is critical, none of those can diagnose cancer.
Only the biopsy can do that.
Correct. The core needle biopsy is the only way to get cells under a microscope and confirm malignancy. You cannot diagnose cancer from a picture. You need the tissue.
That is a crucial distinction. You can have a suspicious mammogram, but until the biopsy results are in, it's not cancer.
Exactly. And that waiting period is often the hardest part for the patient.
So we've traveled quite a distance here. We started with the fear of the lump, unpacked the lumpy, bumpy reality of fibrocystic disease, chased the breast mouse of fibroadenomas, dealt with the painful blockage of mastitis, and faced the reality of cancer.
It's a wide spectrum.
If you had to distill this down, what is the synthesis here? What's the big takeaway?
I think the journey is from fear to empowerment. The source material emphasizes moving away from rigid, scheduled breast self-exams. You know, the old advice of every month, in the shower, do exactly these circular motions.
They aren't recommending that anymore.
The shift is toward breast self-awareness.
What's the difference?
Self-exam often led to false alarms and anxiety because women were hunting for things without knowing what they were feeling. Self-awareness is about knowing your baseline.
Knowing what's normal for you.
It's about knowing what your breasts normally feel like. Do they get lumpy before your period? Okay, that's your normal. Do you have a fibroadenoma that's been there for years? That's your normal.
So you're looking for the change.
Yes, you're looking for the new, persistent, non-cyclical change. If you know you're normal, you can spot the abnormal much faster.
That feels much more manageable. It's not a test you have to pass every month. It's a relationship with your own body.
Precisely. And my final thought is that knowledge is the antidote to anxiety. When you understand the risk, why the hormones make you sore, why the genetics matter, why the lifestyle choices impact your risk, you stop being a victim of bad luck and start being an active participant in your health.
Proactive instead of reactive.
You can make proactive choices rather than just living in reactive fear.
That is a powerful place to land. But before we go, I want to leave our listeners with one final, slightly provocative thought to chew on.
Let's hear it.
We spent a lot of time talking about adipose tissue body fat. We usually think of fat as just weight, dead weight, energy storage. But today we learned it's an endocrine organ. It's actively pumping out estrogen.
It is a hormone factory.
So if obesity is actually a state of hormonal imbalance, how did that reframe our entire approach to health? It's not just about fitting into genes. It's about the fact that our body composition is literally talking to our cells, potentially telling them to mutate.
It shifts obesity from a metabolic issue to an oncological issue. It's a profound connection that changes the stakes entirely.
Something to mull over. Thank you for diving deep with us today.
Always a pleasure.
Take care of yourselves, get to know your baseline, and we'll see you on the next deep dive.